Great. Hi everybody, and welcome to our webinar and fireside chat where we're discussing the key findings around the fourth Australian Healthcare Index report. This report's actually been created by a joint initiative between the Australian Patients Association and Healthengine. The APA, the Australian Patients Association, is an independent, not-for-profit organisation that's dedicated to championing and protecting the rights and interests of patients, improving the patient experience and their health outcomes. And Healthengine, we're Australia's largest consumer healthcare platform. We help around about 4 million consumers every month and navigate the complex world of healthcare and connect them with the right care, making their journeys more affordable, convenient, and certain. My name is Dr. Marcus Tan. I'm the founder and CEO of Healthengine, and I'm your facilitator today. And I'm joined by Stephen Mason, who's the CEO of the Australian Patients Association, Professor Stephen Duckett, who's the Honorary Professor at the University of Melbourne, who's just concluded a decade at the Grattan Institute as the Health and Aged Care Program Director, and also Kylie Woolcock, who's the CEO of the Australian Healthcare and Hospitals Association. So thank you everyone for joining us. I'd like to also firstly acknowledge the traditional owners of the land upon which we're meeting. I know we're in the Zoom land at the moment, but everywhere that we are meeting, and acknowledge their elders past, present, and future. The issue around Aboriginal health particularly, and the inequalities faced by our First Nations people, and the ability for us to close the gap, I think is an important outcome of some of the discussions that we can need as well as part of these types of discussions. We're also joined online by a group of people who are part of the greater healthcare ecosystem and just care about healthcare in Australia. I think it's a great discussion that we can have. And so for those of you online, we'd love to hear from you. There is a Q&A function, so feel free to put in any questions into the Q&A, and we'll endeavour to get to as many of those questions as we can from the panel. So quickly, just about the report, as for some of those who aren't familiar with the report, the Australian Healthcare Index is actually, it's the fourth installation of it now. It's a biannual survey that we do of around about 11,000 Australians who participate in the survey nationally. And you can actually visit this report at australianhealthcareindex.com.au. And it gives you not just a full report, but an interactive dashboard that gives you state-by-state insights in some cases, not just the national insights. One of the things that we like to do is actually give people a sort of, get people to give us a rating of the healthcare system as they see it and as their experience goes. And we've actually seen some interesting results come out of that as time has gone on over the reports. It's pretty clear that we're actually seeing some real decline in, a consistent and gradual decline in that satisfaction rating. When we first started, at the inaugural report, it showed a healthcare satisfaction rating of around about 7.8 out of 10. It's now gone down to 7.1. And as I said, it's, as every report has come out, it's just gradually declined. The top three concerns this particular report centered around healthcare workforce shortages, particularly from GPs and nurses. Emergency department wait times was a significant issue. GP out-of-pocket costs was also rounded out the top three. But certainly private health insurance costs and mental health care access were, part of the top five of all the people who completed the survey. So what I might do is I might actually start the conversation by throwing it over to Stephen Mason, who obviously starting with the patient always in mind first. Stephen, can you tell me a little bit about any stories or anything that you've actually been hearing about what's happening out there, consistent with what you might be seeing in terms of the results of the decline in satisfaction from patients of the healthcare system?
Certainly, Marcus. Before I talk about some of the patient experiences, you did refer to the overall rating of our healthcare system, and this is important trend analysis that the survey goes into. And as the report indicates, back in March 2021, the rating was 7.8, then it dropped down to 7.6, then 7.1, 7.2, then 7.1. So there's been a steady decline over the last 2 years. And that's not surprising because there's staff shortages, the pandemic's taken its toll, and, as the survey indicated, staff shortage was the #1 concern. So we've got retirements, staff are exhausted, and as we know from the survey, we've got longer waiting times for elective surgery. That'll take a long time to recover to pre-pandemic. Emergency department chaos was the number 2 concern. Longer waiting times in emergency departments, long waiting times to see a psychologist or psychiatrist if you've got mental health issues. And the third concern was the cost of seeing a GP and the longer waiting times, and we know there's a shortage of GPs. So that's a major problem for the federal government. There's bed shortages and a lot of other issues. Cost of living is a major problem in the Australian economy at present. We're finding a lot of people can't afford all their prescription medication. And as you alluded to, a lot of people are concerned about the cost of seeing a GP, and it is concerning what the future of bulk billing is, because there's fewer and fewer clinics offering bulk billing facilities. Having said all that, we're facing a lot of headwinds, but a rating of 7.1 is not catastrophic. We're still more fortunate than most other countries, but the trend's not encouraging, and we need to do a lot about it. The main concern we're getting from individual patients is the lack of bulk billing. Patients in lower socio-economic areas and people on lower incomes, I'm talking about 40, 50,000 a year, where they're not on any concession card, are really concerned. They've now got to pay for a visit to the GP. The minimum out of pocket seems to be $40, and that's upward, and that's on top of their prescription medication. So that is very concerning, and that's something the federal government is going to have to address.
Thanks, Stephen. And we'll actually we'll touch on the whole bulk billing and Medicare issue very shortly. I might bring you in, Kylie. I mean, some people may not know the Australian Healthcare and Hospitals Association. It's actually Australia's national peak body for public and not-for-profit hospitals and healthcare providers. I guess from the perspective of the 2 major concerns that was shown out in the survey, the first one was around healthcare worker shortages, and then the second one was longer ED wait times. That's purely in your sweet spot. Can you tell us a little bit about what you're seeing in the system and how they're responding to address these particular 2 important issues?
Yeah, I mean, workforce shortages are undoubtedly one of the greatest challenges facing the system, not just here in Australia, but globally. And I think that's because, firstly, there's no quick fix to workforce. You can't develop them quickly. It takes years to educate through to graduation, but then there's still a number of years to develop that experience to get the senior clinicians and other workforce that we need. And then secondly, because of these workforce shortages, it's placing pressure on the existing workforce. So there's no magic bullet to it. We do need to be looking at some short, medium and long-term solutions. We need to be doing this to, I guess, in the short term is really ensuring that our workforce is supported. We need to be thinking really creatively about some of the solutions. And we're seeing some of these. I mean, COVID was a perfect example of some of these. But I want to be really clear, I guess, when I say think creatively, it's not about second-rate solutions. It's not about subpar care. Really focusing on what are the outcomes we're trying to achieve, what's that pathway of care that a patient's experiencing, and who has the skills to deliver that care where the person is. So I guess if we look at some of those short-term examples, it can be as simple as, considering the nursing workforce and the time they might spend changing bed sheets simply because the cleaning contractors say we don't change, sheets that have potential for bodily fluids on them. A really sort of straightforward example could be that you increase the cleaning contractors so that you're freeing up the time of the nursing staff, protecting that value that you get from nurses that you don't get from them changing bed sheets. But then you could also look at some of the work, I guess quite a different example in New South Wales. We're seeing, them thinking about, well, we've got medical students who they have skills that develop throughout the course of their program. What are those skills and how can we use those? Employing them in medical assisted roles, which makes much more sense, instead of them going out and supplementing their income with hospitality or retail roles, is to actually use them in the workforce itself. And then I guess thinking longer term, it's really about the models of care and making sure we design those around the needs of patients to achieve the best outcomes. The wait times is a really great example and reflection, I guess, of the solution, because the solution is not sitting in the emergency department. The solutions are sitting much more before people actually reach the ED, potentially. You know, how do we provide primary care? How are we providing aged care, health care to people in aged care? But then also the after of how are we discharging patients from hospitals to make beds available for admission. So at AHHA, I mean, as you mentioned, our membership is public and not-for-profit health service providers and hospitals. Really, we don't represent any one part of the system. It's very much about people who want to come together because they recognise that the solutions don't sit within themselves. They're the people who want to connect and think about that whole pathway. And we've been doing a lot of work around value-based healthcare to be thinking about care in those pathways and identifying not just what the services can be doing to connect up that care for people, but to be thinking about what are the policy levers that will help with that, and what are we going to do to ensure that care pathway does achieve those best outcomes.
Thanks, Kylie. So I think there's a lot of threads that we can draw on, but it's a great segue to bring in Professor Duckett. And I'd rather not say Stephen because it's going to get very confusing between the two panelists. So Professor Duckett, I guess, I mean, you're clearly a very prominent health economist. You know, you've got a long track record in the healthcare space, having run, you know, effectively run the department, the previous Commonwealth Department of Health in the past. And as I mentioned earlier, you've been at the Grattan Institute for the last 10 years. You've just joined the Medicare task force, the strengthening Medicare task force that was put together to help Mark Butler, our health minister, actually spend $750 million apparently to improve access to healthcare and, you know, deal with chronic disease and affordability issues. Can you tell us a little bit more about what you're seeing, you know, in that task force? I guess you know, it's meant to be something that is helping to try and fix some of the issues that people are already identifying as problems in Medicare. But have you actually got any sort of insights that you can share with the people on the call?
Well, obviously, I can't talk about precisely what's happening in the task force,
yeah,
but the issues considered by the task force or being considered by the task force are the same issues that you're actually seeing in this survey and the same issues that we've talked about for a while. I just want to pick up on something that Kylie said about workforce. We used to have an agency in Australia called Health Workforce Australia, which was an agency set up to bring the Commonwealth and the states together and to actually focus on health workforce planning. That was abolished in Peter Dutton's budget, 2014 budget, when he was health minister. So it's interesting to me, how long does it take, once you abolish Australia's capacity for health workforce planning, how long does it take to see the problems emerge? Well, they've probably been emerged a little while ago, but certainly after 8 years of effectively no workforce planning in Australia, surprise, surprise, we've got health workforce problems. So we shouldn't imagine that these issues are things we can't deal with. We actually had mechanisms to deal with in the past. We don't have mechanisms now. And some of the solutions are of the kind that Kylie talked about. The second point I want to raise is the survey that is being released, the healthcare index, is really quite interesting, because one of the questions was, why did you give this such a high rating? And one of the questions was, why did you give it such a low rating? And so when you look at that, the people who rated healthcare 9 or 10, really, really good, said good access, good quality of care. People who rated it really, really low said poor access, poor quality of care. So the experience of people is very, very different. Now, we don't know from what you've given us whether that experience of care is geographically determined, whether that, and I suspect there's a bit of a rural-urban problem here, whether it's income determined, socioeconomic status determined, wealthy people have better access than poorer people. But so what we know is Australia is providing good care for some, it's just not providing good care and good access for all. So that means there's an agenda, we know what to do, it's just we're not doing it everywhere for everyone. I'd just like to pick up on the bulk billing issue, which is really important. over this year, 2022, the rate of bulk billing for general practice has declined from about 88, 89% to about 84%. So a significant decline in bulk billing. So obviously that is something that government has to address. It is going to cost, I think, way more than the money available in that 750, which is really 250 million a year. But it's obviously something government has to address. And the real issue is how you're going to do that. The second issue is the workforce issue. And obviously, again, part of that has to be other people doing things that GPs used to do. So, for example, I've got a friend in England who had a pain in his low back. He rang up his general practice and said, I've got pain in my low back. And they said, thanks very much, we'll let you know. And a physio rang him back. Part of the general practice, employed in the general practice, was a physio who dealt with musculoskeletal issues. So not some sort of separate deal, not sort of undermining general practice, but actually incorporated into the general practice. So these are the sorts of things we've got to be talking about. These are the sorts of solutions for the future in Australia. People who are skilled, as Kylie said, people who are skilled in, we're not talking about second-rate care, we're talking about people who are trained to deal with some of these issues, actually dealing with them. So we've got to actually design the financial incentives and the system to make this work, and it doesn't work at the moment.
Yeah, no, I think that's a great summary. Maybe I'll bring it to everybody to make a comment on this one, and it's a big question, but I think it's an important one to put out there. Obviously, Australia's had a history where it's almost a part of the social compact that healthcare, education, a strong and retirement. They're almost kind of expectations that that Australians have that that they've held for a long time, and these are free institutions in a lot of ways, things that are very highly accessible. The idea of universal healthcare, that is this idea that healthcare should be free to pretty much every Australian. Is that an idea or an ideal that's basically dead in Australia right now? I mean, is it something that is no longer affordable?
I think Professor Duckett will talk on this, but look, in any good country, you look after the poor and the needy. And Australia, in many ways, is still a lucky country, still a fortunate country. We should be able to look after the poor and needy. So I think it'd be a very sad day if we did away with bulk billing.
So I'm going to be in Canberra tomorrow and at the National Press Club, where a book is being launched because tomorrow is the 50th anniversary of the election of the Whitlam government, the government that ushered in Medibank, which subsequently became Medicare. Australians love Medicare, partly because it gives us choice of which doctor we go to, partly because for most people, 2/3 of all Australians are bulk billed for all of their general practice visits. And Australia doesn't spend a lot of money on healthcare. If you look at it compared to other wealthy countries, we're in the middle range. So we've got a system that works and we've got access for most. The problem is, as I said, not for everybody. So I think there's no reason to say we can't afford it. We've just got to spend our money wisely and make sure we're investing in the right areas.
Kylie, did you have any thoughts on that?
Yeah, that's really exciting. That tomorrow's that 50th anniversary, and John Deeble, who's the patron of our Deeble Institute for Health Policy Research, and when you sort of think back to, he was one of the people who was the co-architect of Medibank and then Medicare. We do a lot of, I guess, reflection on what it was that he was driving for, and it certainly wasn't saying Medicare as I have designed it. His real drive was seeing people who had cancer who couldn't afford treatment and saying that's not acceptable. And I think that's when we think about Medicare, we need to be tied to that in terms of how do we reform, not be tied to Medicare as the way that it was designed back in the beginning. So I think, looking at how do we shift away from the current way of doing things requires taking into consideration things like who is doing what and how are we funding for it. And I think we're seeing a lot of that transition happening, whether it's through the Independent Health and Aged Care Pricing Authority and the work they've done to look at, well, how would you fund differently and for which conditions would be a good place to start exploring, funding people who have, I think the care pathways that they're looking at, the people who have chronic and complex disease. activity-based or fee-for-service payments are not the right way to fund to incentivise good outcomes. And similarly, it's people who have a consistent care pathway. So it might be someone who goes through, knee replacement through to rehabilitation. It's a fairly standard pathway for each patient. So how would you fund for that to, again, incentivise, the right care being given to the person at the right time?
Yeah, and look, I'll jump in here as well. I think, the idea of bulk billing, which obviously in the past has been where the patient rebate is effectively being used as the payment that the practices accept as, as full payment. That obviously assumes that the practice is happy to accept that payment to cover all their costs. I think the difficulty here is that, and for those who aren't aware, I'm a GP and a practicing one as well. And a lot of my colleagues certainly have felt that in an environment where the indexation of Medicare has not actually met the escalating costs of delivering quality healthcare in general practice, and also, I guess, the blunt instrument that looks a lot like a level B consult that is just around about $30 of rebate to cover the standard consult. The cost of operating a practice in Toorak is not going to be the same as operating a practice out in the Northern Territory as compared to what it might be in outer metro in, say, Perth. These are all very different cost bases, I guess, to deliver the same sort of care. And yet the Medicare rebate is by and large the same no matter where you go. And so the effective ability to balance up the cost with what patients can afford, these are the things that sometimes GPs themselves have to wear. And the idea that they have to now sometimes be gatekeepers, not just for the healthcare system, but also for whether people are eligible to get bulk billing, and these sorts of things become quite difficult. So this is where I suppose the interface between human services and the eligibility for things like bulk billing and access to free healthcare, which is seen as a right for everyone versus it's a affordability thing and access thing for those who can't afford it, or who seem to be less advantaged when it comes to their economic situation. How do we actually find that that change that expectation perhaps from the public, where those who can afford to pay should pay privately and have some out-of-pocket costs potentially to help the sustainability of the healthcare system, and identify those who genuinely are in financial need to actually give them the ability to access healthcare without facing huge out-of-pocket costs? What can we do about that? Professor Duckett, do you have any
So Marcus, I totally and completely disagree with the premise there. I mean, the whole point of Medicare and Medibank was it was a universal scheme. That is, it replaced the old highly targeted schemes. And I'll just give you a story. One of my first jobs was working in a public hospital in Sydney, and I was the acting revenue officer, and I had to take people to court because they couldn't pay their hospital bills. These were not pensioners; these were people just above the income cutoffs. And so Medibank was designed and always designed to be universal. So we shouldn't think about Medibank as being something for the poor people or small whatever with Medicare. We've got to think about Medicare as being universal. And also, wealthy people already contribute to Medicare more than poorer people because they pay more income tax. The question is, how do we make sure Medicare and its rebates are fair for general practitioners so that they're not forced into this very difficult situation of saying, look, we want a bulk bill, but the rebates haven't gone up in line with average weekly earnings. They've gone up in line with CPI, but not in terms of the cost of running a practice. So I think, we've got to think differently. My own view is we should have an independent fees tribunal which says this is a fair fee for what we're trying to do, and we shouldn't ask GPs, for example, to freeze their government should not freeze fees and say to GPs, well, I know your costs are going up, but your rebates are not, and we don't care, and we expect you to bulk bill. We've got to be fair to both the providers and the consumers, and we can afford to be.
Professor, do you think the fee or the rebate should be postcode adjusted?
I think Marcus's point is absolutely right. When Medibank and Medicare were first introduced, we had different rebates for different states, which is a bit of a crude measure, but certainly I think we've got to recognise different different cost structures that practices face.
I certainly support your idea of an independent, panel or body to assess the fair fee. It'll take the politics out of it, and as long as they're suitably qualified, hopefully no one would complain. I'm sure they would.
I think the other issue is that, and it's certainly something that no doubt you're discussing at the Strengthening Medicare Task Force, is this idea that fee for service and activity-based funding that a lot of hospitals, I guess, have adopted. Kylie, you mentioned the idea of moving to values-based healthcare, which tends to be more outcomes-based. I do wonder, is that something that's likely to be coming sooner rather than later? The changing mix of how Medicare was delivered from fee-for-service to the concept of healthcare homes and these types of things where it was more capitated and it was more on a population basis. These are all concepts that have been put on the table, but it's pretty much gone quiet. So is that something that we're likely to see come back as part of the discussion?
I think it really needs to come back as part of the discussion, and I guess I'm hopeful, given the expansion and objectives and the name of the Independent Hospital Pricing Authority, to expand its remit to health and aged care as well. It's because I think one of the challenges you have, if you look at if you're funding the system in silos, you're going to get shifting of and not incentivize care in the right way. Similarly, if you're thinking about funding different health professionals under multiple different mechanisms and approaches, again, you're going to not have aligned incentives to actually give patients the best care. So I think there's some good work that we can build on, but it does need to be thinking about that full care pathway when it looks at it. And I think the other thing that needs to be thought about is, and as has been alluded to already, those shifts in financial risk or in risk more generally in shifting to value-based payment models. It's not something that can be introduced overnight. It shouldn't be done in silos. There needs to be sort of a comprehensive framework or plan in place that steps out the shifts that are going to happen. We've got to accept that we may not get it right first time, but that we're shifting towards an approach so that people can adjust their business models, we can mitigate some of these risks and not put it again back on providers just to accept all the risk that comes with that.
Yeah, I agree with that. So, Medibank was designed in the mid-1960s. Healthcare looks nothing like the mid-1960s. Both the diseases that are more prevalent and also the way practice, the growth of corporate practices and so on. So it's totally different. And yet our fundamentals of the fee arrangements and the payment arrangements haven't changed. So what you've got to step back and say, okay, let's look forward to sometime way into the future, 2050, for example, or 2040. What proportion of a general practice income ought to be fee for service? Because fee for service has some strengths. What proportion ought to be on some sort of per patient per month basis? And what proportion ought to be incentives for improved outcomes? And the answer to that in 2040 or 2050 is not going to be as it is now. So the question is, where do we want to get to, and over what time frame is it that we want to get there? And I think that's the issue for policy.
Well, I mean, on that basis, Professor, we also, I guess, have had the narrative that the evolving case mix of morbidity has shifted from back in the early part of last century. It tended to be more acute infectious disease, that type of thing, and then as lifestyle changes have evolved, it's become more chronic disease focused, and things like diabetes and heart disease and these sorts of things have obviously become more the purview of the primary care sector and community sector. So much so, in fact, that we talk about primary care and then we talk about the acute sector being more the hospital sector. I guess what's happened in the pandemic is that we've actually seen the primary care sector actually slammed with both having to deal with the acute stuff, which is the infectious side of things, and having to deal with the burden of aged care and mental health and chronic disease. And so I guess the amount of demand that's going through the primary care sector, not just in a preventative sense, but in an acute management sense, is also high. And particularly given that the funding mix, I guess tends to be shifted between cost to the state versus cost to the federal side of things in terms of public hospital spend. These are, I guess, different factors that are pulling and pushing the entire healthcare sector around how to manage demand. I guess it's an interesting question around how the funding and the financing system actually works, because you raised the issue of corporates, and I guess to the extent that most of the community sector, or at least the primary health sector, are mostly delivered through private care. Do you feel that that's actually something that needs to change in order to create that sustainability, or for providers to actually deliver something that's a bit less under pressure and less of that sausage factory, because the turnover is what a lot of private care, particularly in FIFA Service, happens? George Margelis has actually raised a question around, do we think that governments should be salarying GPs, for instance, versus having the FIFA Service type of model in the private sector?
Marcus, with these super clinics, the government plans to open up, I believe a lot of the healthcare professionals will be salaried people. And as we know, in remote parts of Queensland, there's a lot of salaried doctors. But while we're talking about this funding system, which is critical because, as Stephen said before, the FIFA Service is applicable in some instances, but not others, where you want the patient to recover quickly. You don't want the incentive of them coming back to the doctor all the time. And I hear people complain that the chiropractor, the physio, you never get off the list. You're always back to see them. But one of the key issues from the survey was mental health. And we know a huge percentage of people are suffering from mental health. 39% regarded that as a top 3 issue. But they're not able to get in to see a psychologist. The books for psychiatrists are closed. When we talk to a lot of GP clinics, a huge percentage of the visits are in relation to mental health. And I think if it's just a fee for service, it kind of lacks the incentive to get the patient better, so you actually lose the patient. And that's where I do like to see incentives to get the patient better off the books, even if there's a reward for, an outstanding effort. I'm always one for rewarding outcomes, not necessarily effort.
I can add to that one, Stephen. Yeah. We have a clinical psychologist who had wrote a paper for us. They had attempted to sort of engage in some conversations about how to measure outcomes in a way that they could sort of look at their cohort of people that was coming to them. And they started actually publishing the outcomes across their cohort on their website as who's getting better in what timeframes and what. And they found a way to look at the cohort, I guess, in a consistent way. But what really, while there was no change in funding structure for this clinician on their own, was to look at, well, why are people, what was happening in those consultations that made people recover more quickly? What were the people, what made people continue much longer in the course of treatment, and what could he do differently to improve those outcomes? So I think there's also a real benefit to having the data available, and that's something that we really need to be thinking about too, is putting that data in the hands of a person who can actually make a difference and change the way that care is provided. We see a lot of work around benchmarking in hospitals, but I guess we don't see a lot of that in the primary healthcare or mental health care space.
Was that information shared so others could benefit from it?
They were doing it as a personal to improve their practice. They were actually struggling to get sort of engagement from colleagues to also join them in this endeavour and look at sort of provide that benchmarking. But I think they're certainly interested themselves, and I think there's great opportunity for us to sort of help, I guess, support him in that quest from a mental health perspective.
Yeah, I'm also aware that some of the primary health networks are actually engaged in some sort of a process to try and get some better visibility on some of the, what's happening out in the community, particularly in primary care, and how general practices and others are actually working to actually create some of those benchmarks. I think that that's a new piece of work, but it is actually evolving and growing. I've got a couple of questions, and thank you for those who are actually putting questions into the Q&A. Some very interesting ones. Some of them are actually being dealt with as we're talking, but I just want to touch on just to loop back a little bit on one of the things that I did raise around medical homes. I think that was, and George Margelis again has asked this question around medical homes pilot being fairly inconclusive and whether it improved outcomes and costs. Is there any evidence-based solution that actually works better than fee for service at the moment? to on that?
The evidence is actually quite mixed about different payment methods. So I don't think it's unequivocally true that fee-for-service is always better than capitation, or that capitation is always better than fee-for-service. And what's happening internationally is increasingly people are saying fee-for-service works well in some areas and capitation, or per patient per month, works better in other areas. And I think that's what we have to recognise. It is not an all or nothing, but it is what incentives does the current system create? Well, the current system creates incentives for short consultations, dealing with one problem at one time, rather than dealing with the whole patient and all their problems at one time. So there's a whole lot of, we've got the incentive structure wrong, and surprisingly, people are not happy with it. So we've got to actually say, what will be the mix of payment methods, rather than saying one is right and one is wrong.
And I guess with with this discussion, I mean, we've talked a little bit about healthcare systems, and particularly maybe examples around the world of how some people are doing it. And I guess the NHS tends to be used as the exemplar of like socialized medicine, and the US system sort of more on the private side, whereas it feels like Australia has struck a bit of a happy medium somewhere in between. In saying that, though, that mix of private to public, we're starting to see the emergence of quite a lot of, certainly in WA anyway, of private emergency departments. And I wonder, Kylie, whether you feel like that's, particularly given that people are saying that their out-of-pocket costs associated with private health insurance seems, the insurance system isn't seemingly working on the private side and the public side with Medicare. What's going on? Like, I mean, how are we going to fix this, without creating this two-tier system where now people have to pay, and this, as I said, this universal healthcare system, basically that ideal is actually pretty much gone?
Yeah, that's a big question. I think, to have that, national conversation around the role of private health insurance in supporting universal healthcare is one that needs to be still had. We tend to have sort of more narrow inquiries into different elements without sort of agreeing, or what's the purpose and what's acceptable, I guess, in terms of us as a society.
Maybe we need to have a discussion about the scope of private health insurance, because some countries like Canada, you can get cover for your drugs and medicines. It's just, if we're looking at everything, we might as well not leave anything off the table.
Well, I think the separation of this idea that things that are covered by Medicare can't be covered by private health insurance, and vice versa. This idea that, in speaking to quite a lot of private health insurers, I think a lot of them would like to have that continuity of that patient to be able to help them throughout their entire journey, not just have that pocket where, it's outside of the GP consult or outside of the specialist consult where they don't actually have a great deal of visibility. Is that something that's likely to change, Professor Duckett, do you think?
I have not seen any discussion of that in the last 5 years, really. So I doubt it's going to change much. I mean, I know the private insurers like that idea, but there are both strengths to it from the private insurer's point of view, and there are weaknesses to it, because it may mean the total collapse of bulk billing. If the private insurers say, for us, we'll give you another $10 for doing X or Y. So I think it's a bit, the benefits are not unequivocally good.
But right now, I mean, given that most people, and I think Stephen alluded to this earlier on when he was sort of talking about the macroeconomic conditions that everybody's facing, I think there are some significant headwinds that probably we're going to see in the next couple of years. And certainly given the amount of pandemic funding and other things, a lot of governments are pretty much struggling with budgets and other things. I mean, for a start, the Strengthening Medicare Task Force has got, on my understanding, is $750 million to work with. Is that enough? I mean, what are we talking about in terms? Will it even touch the sides?
And that's over 3 years, Marcus.
Yeah, that's right. So what are we talking about in terms of quantums of funding to actually make Medicare more universally accessible then?
So I think it partly, I mean, my view is the 250 million is not enough to fix everything, but I don't think it's ever been sold as enough to fix everything. It's in a sense, a down payment. If you recall, the Labor Party went into this year's election with a inverted commas small target strategy. It went into the 2019 election with big spending and big taxing proposals and was monstered. And so they decided, we're not going to propose big, we're going to propose small, which is what they did. And so they didn't say we're going to fix everything with the money we put on the table, because that's what the public voted against in 2019. The public voted against a universal dental scheme. The public voted against a massive expansion. And so, we've got to actually remember there's a political context to this. And the context is a government that went in with a small target strategy and not saying it's going to fix everything.
And noting that, and Albanese seems to be a man of his word who wants to honour all his election commitments and pledges. But from the point of view of the Australian Patients Association, we've been a strong advocate to include dental care in Medicare. It's unfortunate Gough Whitlam couldn't convince the dentist 50 years ago, but unfortunately they didn't come to the table then. And it's going to be a tough ask, but we get so many complaints about the cost of dental care here. We really need, the Australian Dental Association really needs to start talking to patient groups. I know with the super clinics, it will cover dentists, and some of the state governments have got schemes to help needy people and school children with dental care. But too many Australians don't have a regular dentist. Too many Australians don't look after their oral care. And as a result, they have ill health and end up in hospital, and it indirectly costs us, even though there's a big time lag. Now, I know the government can't afford to do this now, but I think as an ultimate aim, I'd love to see dental care as part of Medicare.
So, Stephen, I think the ADA has moved a long way in the past, and I think they now support some sort of universal dental program, and you won't find a stronger support for universal dental program than me. However, the government did not go into the election with that on its agenda, and I don't think, my own view is I'm not going to advocate for it to be done this term. I'm certainly going to advocate for it to be on the agenda for the next election, but I think we've got to honour what the government, the commitment and the contract, in my view, between the government and the people from the 2022 election.
No, I agree with you that this is a longer term aim, not in the next 2 years, but probably 5 to 10.
And it's also a great opportunity to learn from some of the work that's being done in the public dental health space around shifting the way we think about dental care, that it's not just about what's provided by a dentist, but the dental hygienists, the oral therapists, even the educators who can support some of the preventive work around in oral health that doesn't have to be delivered by a dentist. So again, it's about how do we use our workforce, effectively to improve the outcomes. And then again, how do we design the governance mechanisms and the reporting and the data and the funding so that it actually supports improved outcomes.
And with dental, we've got an opportunity to start differently from the way we started with Medicare. I wouldn't start with a FIFA Service, uncapped, unregulated FIFA Service system. I'd start in a different place.
Yeah, and I think that's the issue, isn't it? Is that if we all had a clean slate, knowing what we know now, it'd be much easier to create the ideal system. But right now, the change management of something that's been in place for as many years as it has been, it's not the easiest thing in the world. I think one of the comments that was made is that billing complexity, for anyone, particularly GPs, isn't going to be a popular change. It's already complex enough. Having all the different tiers and other things makes it, so much more difficult. And when you start talking about value-based, outcomes-based sort of type of things, the first thing that will often come up is, well, how much control can a GP really have on patient behaviour and other things? And that's where things like adherence and compliance and these types of things start to become more into play. So, you know, it becomes very complex. I just want to quickly touch on something that Stephen's mentioned a couple of times that seems to be on government agendas fairly regularly, but I'm not ever sure whether the evidence is there that it actually makes any difference, particularly given that we've got such workforce shortages that we're facing. And that's this issue of super clinics. We've seen this, you know, for over the decades. There's been various policies around the introduction of super clinics. And I remember them sort of being put into the agenda back in the 90s. These are the sorts of things that seem to come up when people run out of ideas and think that, well, actually government clinics are the ways to go, because the private clinics don't seem to want to come to play, you know, with the bulk billing thing, when in fact it may actually end up causing competition, if you like, or at least you know, a distortion in the market for private practices who now have to have a government-funded competitor in the market as well. Where is that balance between, you know, those types of scenarios where we're clearly not getting enough access, but, you know, and affordability is an issue, whereas you're now creating potential market distortion, which makes it even less viable in the private sense? How do we deal with that aspect of it? And by the way, is there any evidence that super clinics actually help the situation?
So my view is that you start making sure you've got the right financial incentives. Basically, primary care is essentially 95% private business. And so you've got to actually say, well, one of the things we know about private business is that they respond to financial incentives. And so we've got to get the financial incentives right. And so I'm not sure that the right answer is, I thought super clinics were not going to be government provided anyway. But anyway, so if they do exist. But anyway, so I think we've got to think through what are the financial incentives for the vast bulk of private practice. And I'm pretty sure we've got the financial incentives wrong now, and we won't know what the right answer is until we actually change what we've done. And we can be pretty sure there are some things that are wrong, including the relativities. It's much more financially remunerative for a doctor to see someone for 7 minutes than it is for a doctor to see someone for 37 minutes, whether or not the right answer is 37 versus 7. So I think we've got to really think through what the financial incentive should be, what should be the structure of the fee schedule, and all those sorts of things. And we have sadly neglected to do that for too long.
Kylie, Stephen, did you have any other comments about super clinics?
Not about super clinics specifically, but I think it's a really important point, though, to think about what the market is that you're entering any of these sort of new services. And we see it with we've seen it with virtual care as well. You know, you have to think about what's the impact on the services that are actually delivering the care, because you can't do away with face-to-face care in all instances. So to have a much more place-based approach to how we do some of these innovations and deliver care really is an important to ensure that we don't distort markets in a way that's not actually best for the community.
We're actually coming very close to time, or at least we haven't got that much time left. What I do want to quickly ask, though, is that there was this conversation about ED wait times that talked a lot about managing patients' demand from, you know, making sure that there's no inappropriate use and having the community side of things bolstered up so that people aren't going into private emergency departments, public emergency departments inappropriately. My feeling is that the fact that a lot of the out-of-pocket costs at general practice and the diminishing of bulk billing is occurring, we'll probably see more and more activity happening in private, in public hospital emergency departments, largely because it is free and it's out of pocket. Is there? Sorry, there's no out of pocket. Is that something that anyone's seeing as a particular trend that's actually happening?
Well, we are, and we're getting more and more calls from people, and a lot of them have mental health issues, and it's a last resort. So they're going to the hospital Sunday night at 10 o'clock, 11 o'clock, and the hospital's not always adequately staffed. And so the environment's generally not conducive. It's a big issue. but it's a whole of health issue. I think we need to look at other places to look after those with mental health issues. It's got to be 24 hours a day, 7 days a week, but smaller, more intimate, more personal environments. But I think a lot of people are aware of that, and I'm hoping something will happen. One thing we haven't discussed today, which was in the survey, is the growing waiting times for elective surgery. And I know with Professor Duckett, with his time at the Alfred Hospital, that's always been a keen interest of his, and separating emergency departments from the public hospital for elective surgery, so they're not competing with each other.
Stephen, thank you very much for that segue.
Nice.
When I was chair of the board of the Alfred, we proposed what I crudely called an elective surgery factory, but which is now called the Alfred Centre, an elective procedure centre, and other places are now doing it. It was the first public one in Australia. And what we did was have a dedicated elective procedure centre that only does elective procedures, and people only stay 3 days. And it was separate from the emergency room, because at the Alfred, when I was first appointed the board chair, the CEO said there are 2 things you've got to fix. One is car parking, and the other is we don't do any elective surgery other than category 1. And so that's what I dealt with. And it's absolutely essential we deal with the long waiting times, partly created during COVID, but we now need to be moving on from that and actually working out how we're going to do it. And we may have to think about elective surgery, elective procedures very, very differently. We might have to say, well, hello, we're going to actually start questioning whether every hospital should do orthopaedics, elective orthopaedics, and we might actually concentrate some of these things in, consolidate the waiting lists, concentrate the services. We might have to say, before you see the orthopaedic surgeon, you're going to see a physio for that low back pain, because surgery may not be the answer.
Kylie, is this an issue that has concerned you?
Yeah, look, and that last example is one that we've been doing a lot of work in space with Allied Health in terms of how do they provide support for the people who are on the waiting lists, which may actually stop them from needing to be on the waiting list at all, whether it's the audiologists in pathways of care before they see ENTs, or as Stephen said, the physio with low back pain. I think the assumption that the waiting list is the right waiting list, that the people on it should be on it. I think we need to take a step back and actually say, well, how do we actually manage these people? And you have the double benefit of saying, well, actually they could be managed through their pain or whatnot through a different pathway. But should they still need the surgery, they still, they don't lose their place in the queue while they explore these other alternative treatments.
And we talk about elective surgery, and a lot of this discussion clearly is all interlinked in many ways, as most of the health sector actually is. I mean, Kylie, you mentioned sort of the idea that demand management on the one side is in community, but then there's also the idea of hospitals being able to manage their beds. Bed block is certainly an issue that I hear about, that causes not just ambulance ramping, but ED wait times and all the other things to be an issue. One of the things in speaking to various parties around some of the reasons for bed block appears to be a combination of the mental health issue that Stephen's talked about, the inability to have step down services into the community to safely manage mental health patients, and the longer term stays that tend to be in mental health, but also the aged care issue, where a lot of people who are admitted are again from aged care facilities and probably should be managed in a different way. Are there sort of solutions that we need to be considering in those situations that don't end up potentially stigmatizing mental health as a separate thing that isn't health? It's just we end up with asylums and the usual sort of issues that we've had in the past. And with aged care, are there any other solutions that that you've come across that might be able to help the situation that we've seen?
Yeah, I mean, I was talking about the aged care one. There's certainly been a lot of work in that space of this, whether there's sort of a stepped place that they can go outside of hospital, and talking about, and discharge people into the care of their GP. I guess the challenge is whether their GP is, accessible to provide the care in whatever it is, the place that they get discharged to. And so sort of flipping the thing and saying, well, perhaps it's a GP can take their patients out is another mechanism. But, you know, it is a model that has to really consider what's available in this and what's the model that will work in this place.
Kylie, talking about aged care facilities, we talk to everyone, nurses, ambulance drivers, paramedics. And the complaint we get from a lot of ambulance drivers is that they're always called out to certain aged care homes that don't have staff after 10 o'clock. And so they're told just to call for the ambulance, right? Because they don't have the staff, and that's tying up resources. They're saying people could be critically ill in a car accident, a stroke, a heart attack, and they're at this aged care facility because they haven't put on the resources, and we're the last resort, and we've got to go. So there's a few issues there that need to be dealt with.
So there's issues on the demand and the supply side, Stephen, I think. You might actually start to compare residential aged care facilities on the extent to which they pass the buck off to emergency departments, for example, and say, look, you know, some people are better at this than others. Some look after their patients and their residents and others don't. Second point is the Victorian government, and probably other states as well, have set up a virtual emergency department based out of Northern Health here in Melbourne, which, amongst other things, is able to reach out to these resi care facilities, and the resi care facility can ring the virtual ED and say, well, we've got this patient of this kind, what should we do? And they can get advice over the phone about what they should do rather than sending them automatically to the ED.
Well, that's a good initiative. I hope all aged care homes are aware of it.
And also that 24/7 registered nurses, I think we'll also see, you know, having people on site all the time. But again, they are looking at, you know, we're starting to anecdotally hear some sort of flow-on effects that by having set numbers required for registered nurses and personal care workers, enrolled nurses are being, you know, let go of because they don't require to have them, and they've got a set budget to work within. I don't know the figures around that yet, but I think it is something that, you know, we need to be really conscious of. When you start to implement sort of prescriptive ways of doing things, there can be unintended consequences which may not lead to the best outcomes in the long run.
That's great. Well, look, it's been a good discussion. I might just round it off by asking a question without notice. If you had a magic wand and you could fix one thing right now, what would it be? Is it workforce? Is it money? Is it more beds? Like what is it? Kylie, are you happy to jump in?
Yeah, look, they're all interrelated, so it's difficult to pick one. But I do think, you know, a workforce strategy that thinks about the workforce in more than just doctors and nurses and thinks about the whole team is going to be a really important factor going into the future. Professor
Duckett, do you have any thoughts?
I was hoping to go last and say, look, I support all the previous ones, so I certainly support what Kylie had to say. But I think I'm still worried about climate change. I'm still worried about the pandemic. So some of the public health issues are at the top of my mind.
Great. Well, I generally like to start and end with the patients in mind. So that's why I give Stephen the last say. So Stephen.
Thank you, Marcus. Well, the pandemic hasn't gone away. COVID hasn't gone away. So it's a major concern. But if I had a magic wand, I know the workforce issue is a critical one, but it's going to take a long time to fix. And I like the thought of innovation. The doctor doesn't have to do anything if a nurse can do it, or a chiropractor, some allied health, just share the load, because we've got under-resourced facilities available. But my magic wand would be trying to clear the backlog in elective surgery. The patients we hear, and I'm not talking about the category 1, but these ones are in pain and suffering, but it's not life-threatening, but it's really impacted the quality of life. And some of them have been waiting 2 years. I'd like to see an innovative solution whether we've got to use a few more private hospitals or get in staff to work weekends, but just really have a big focus on that for 6 months to, you know, bring the backlog back into line.
Great. Well, look, I think that's a great way to finish. Again, thank you for a wonderful conversation. Thank you for those people who've put in those questions, and hopefully we've answered most of them. Some of them were quite interesting comments as well. For those who have got a greater interest in digging into the Australian Healthcare Index, you can visit it, as I say, at australianhealthcareindex.com.au, and you'll get access to that interactive dashboard. Thank you for all the panelists and for all who've joined today, and hopefully we'll see you again next time. Thank you very much.